about upper GI bleeding. So we'll restrict ourselves to upper GI bleeding. We're not going in detail with the middle or the lower GI bleed. And what are the challenges that we face day to day, and how do we handle? This is how we are going to discuss this topic. We should always be aware of the reasons. How do we approach a patient with GI bleed? Because GI bleed is the common condition that we encounter day to day in our ICUs. So, for the introduction, upper GI bleed, it continues to be a common gastrointestinal emergency. So, it is the most common gastrointestinal emergency that we see in our ICU. It carries significant morbidity and mortality to the patient. So their hospitalization, the length of hospitalization, everything depends on how it is addressed and how fast the bleeding is controlled. We have to do appropriate risk assessment, and we have to stratify the patient. They are very crucial for optimum care. So we need to know now, because many diseases indicate the need for antithrombotic and antiplatelet agents. The medication history is very important, especially antiplatelets and antithrombotics, and those medications which can cause gastrointestinal erosions. So we need to focus on medication history. So what are the causes for upper GI bleed? So the causes are divided into non-variceal causes and variceal etiology. Earlier, non-variceal causes used to be common because of peptic ulcer diseases. Now, with the introduction of PPIs, there is decrease in incidence of peptic ulcer diseases. It is approximately 20 to 40%. The other causes for non-variceal bleeding is esophagitis, diffuse lesion, angiodysplasia, and neoplasms, that malignancies of the area. So we'll discuss both. How do we approach variceal bleed and non-variceal bleed? Variceal bleed is mostly because of cirrhosis or portal hypertension. Any reason which can cause portal hypertension can cause variceal bleed. So, causes of UGI bleed, the majority of causes is peptic ulcer disease, 40 to 60%. As I told you, with the introduction of PPIs and over-the-counter cell, the peptic ulcer disease induced bleeding coming down. But with the use of antiplatelets and medications that can cause gastritis, there is still an incidence of prevalence of 40 to 60% of peptic ulcer disease. Next cause is esophageal or gastric varices, which attribute to 4 to 16% of the causes for upper GI bleed. Gastritis or duodenitis causes 18 to 20%. Esophagitis in that causes 8 to 20%. Angiodysplasias is 4 to 6%. Mallory stare is 5 to 7%. Ectasias cause 2 to 4%. Malignancies around 2 to 4%. And Dophalis lesions around 1%. So whenever we get a patient with GI bleed, we need to ask thorough history to determine the site of bleeding and the duration that the patient might be bleeding from. Any GI bleed can be occult or it can be overt. Occult, it can be detected by routine evaluation of stool. We have to look for blood cells, whether the RBCs are present in stools or not. And these patients will have anemia. So when we are evaluating for anemia, especially in an elderly patient, we have to look for occult. We have to send stool for occult blood. Then the overt causes of upper GI bleed include hematemesis, that is vomiting of red blood or coffee ground material. So we need to differentiate whether it is fresh blood or it is an altered blood. Is it associated with melena? If it is associated with melena, what is the color of the melena? Is it bright red? Is it tarry stool? Is it black? So all these things we have to know. If it is black or tarry, that means tarry means it may be a continuous bleed. Black intermittent maybe it is upper GI bleed which is coming out 1 or 2 days later. And the patient may be bleeding since 1 or 2 days if it is coming intermittently. But if it is coming continuously, it could be the patient may be bleeding heavily. Hematocysia is passage of red or maroon material per rectum, that is fresh blood. Usually says it is from the lower GI. Occult blood, we discuss what is the duration of the onset of bleed. What are the associated symptoms, whether it is painless, whether it is painful, whether is it associated with colic abdominal pain. So all these things associated symptoms we need to know. Whether the patient is an alcoholic, ethanolic, and there may be a alcohol-induced liver dysfunction. Is the patient smoking? It's at risk of peptic ulcer disease. And as I told you earlier, we have to have a thorough, detailed medication history. So to see whether what are the medications which can cause erosions, what are the medications which can cause inhibit platelet aggregation and increase coagulopathy leading to increased bleeding. So all this medication history we need to take. So whenever we get the patient in ER or ICU, we need to uh, triage them and manage their shock. These patients usually come to us with hypovolemic shock. So because of their blood loss, sometimes it will sudden onset, especially variceal bleed. It can bleed torrentially and cause hypovolemic shock. These patients can come with hypovolemic shock. In a patient with chronic liver dysfunction, the blood pressures is already in a borderline state, and with that, if there is loss of volume, it can cause severe shock. We need to ensure big bore cannulas are placed so that we can rush fluids and blood and blood products can be given. We have to send the blood for coagulation workup, hemoglobin CBC, organ function tests like liver and kidney functions, and we need to reverse the coagulopathy within 1 hour of the patient's. As we need to at least try to reverse it within 1 hour, or we have to send this workup and at least have the results within 45 minutes, and we have a plan of action. So whenever we are triaging, uh, one important score which comes up is Glasgow Butchford score. So in this, they are identifying the risk factors at admission, and they have given a factor score. So for example, if the blood urea nitrogen is this is in milligrams per dl. If it is the level is like that, the score is assigned. And hemoglobin, depending on how much is the loss, the score is assigned. If the hemoglobin is less than 10, the score is 6. If, depending on the BP, heart rate, hemodynamic parameters, and also patient whether the patient has melena, whether the patient has syncope, whether the patient has hepatic dysfunction or cardiac dysfunction. So all these factors are taken and score is given to the each parameter, and then total score is calculated. So these are the parameters and this is how the scores are given. So once these scores are there, if the Glasgow-Butchford score is 0 to 1, that is only one score is there, then it is very low clinical risk. This indicates that it is more of a false negatives, and the risk is only 0.1%. And if you can observe and counsel the patient and discharge them from emergency department, ask them to come on outpatient for further workup. If the score is 2 or more, then there is more than 1% risk of severe bleed. So we have to admit the patient in the hospital and observe them. So we need to resuscitate them. We have to give attention to active comorbidities, control the comorbidities, RBC transfusion if the hemoglobin is less than 7. If there is IHT, we need to accept hemoglobin around 8 to 10 grams per deciliter, and we need to give them erythromycin and then take them for endoscopy within 24 hours of presentation. So we'll discuss about endoscopy and other things subsequently. The another scoring that is very important is Racal scoring. So these are all the triage scorings that have been employed to know whether which patients need to be admitted or which patients can be treated on an OPD patients. And they say the previous scoring is better than Racal scoring. But for completion's sake, we need to know Racal scoring. So depending on the variables like age, what are the comorbidities that the patient is having, whether the patient has presented with shock and the source of bleeding even after endoscopy and segment of recent bleeding. So all these things are taken and they have been given a score of 0, 1, 2 and 3 depending on all these things. So low risk is score less than 2. That means these patients have very low risk of adverse events and they can be, there is the low risk of rebleed. You can suitably early plan early discharge of these patients. The moderate risk is 3 to 7. That means to say these are, we will have to be monitored for rebleeding and other things and there is chances of complications. High risk is highest risk and requires ICU care, and these patients have to be in the ICU and monitored in the ICU. So once we triage and take them in, we need to take care of their, like any other critical ill patients, we need to take care of airway, breathing, and circulation. If there is a massive bleed or altered our mental status, then we have to intubate these patients and connect them on mechanical ventilation. This is for airway protection and it also helps to facilitate endoscopic procedures. Otherwise, the patient will be retching and we won't be cooperative and it will be difficult to visualize. And if the endoscopist want to do some procedure or banding, the field keeps moving. So it is safer and easier if we intubate and sedate and paralyze them, the procedure time will be shorter. And we need to assess for the circulation, give fluids and resuscitate them. We need to follow restrictive transfusions. We don't have to give too much blood. The target hemoglobin is 7 grams. In an IHT patient, if you keep more than 8, that should be sufficient. Because overfilling increases the portal pressures and that tends to bleed till the hemostasis is achieved. We don't have to overfill the patients. So we have to do controlled resuscitation and restrictive transfusions have to be employed. So once we stabilize them, we have to evaluate them. We have to look for the features of chronic liver dysfunction features are there. Uh, whether we have to send laboratory tests for CBC coagulation profile, liver function tests, kidney function tests, radiological function assessment of liver, ultrasound abdomen. Sometimes if the endoscopy we are not able to do or not able to control after endoscopy, then you'll have to consider for CT abdominal angiogram to look for site of blood leak. Then after this, we have to simultaneously think of pharmacological bundle. So what are the drugs that are commonly used? So proton pump inhibitors, pantoprazole 80 mg bolus and 8 mg per hour infusion. This is to control acidity to reduce chances of bleeding and rebleeding. So prokinetics, erythromycin 250 mg IV 30 to 60 minutes before endoscopy. It if it is available, it can be given. It enhances gastric emptying. It helps in good visualization of the stomach and other structures. So if we have a variceal bleeding, we have to consider measures to reduce the portal pressure. So what are the drugs that we can use? We can use octreotide. The dosage is 50 micrograms stat and 50 to 25 to 50 micrograms per hour infusion. Somatostatin, the dosage is, sorry, somatostatin, the dosage is 250 to 250 mics and 250 to 500 mics per hour dose can be given. Terlipressin is 1 mg boluses 6th hourly. And we have to remember whenever the patient has a variceal bleed, we have to give them ceftriaxone antibiotic because these patients are at risk of secondary bacterial peritonitis. So we have to cover them with ceftriaxone. Otherwise, these patients later on go into hepatic encephalopathy. And if there is a variceal bleed, we have to consider OGD within 12 hours. Otherwise, we have to consider within 24 hours. So, endoscopy has to be considered within 24 hours. If it is a variceal bleeding, we have to consider within 12 hours. Or if the patient is very unstable, we can consider it little earlier. So, whenever we do an endoscopy, it can be, as I told you, urgent. It is if it is a patient is variceal or unstable patients within 12 hours, we have to do. Early for other patients, we have to do within 24 hours. And there is a pros and cons of bedside versus endoscopy suite taking these patients. Bedside means getting the endoscope into the critical care area and doing the scopy bedside. The advantage is we are not moving the patients. Patient is in the ICU and intensivist is comfortable handling any emergencies, any hemodynamic instability is there. But the disadvantage is for the endoscopist because the endoscopy staff and the medical gastroenterologist is used to his uh, procedures in the endoscopy suite, and the endoscopy table, suction, all those things will be suitable. And if there is an accessory needed, any accessories, it is easily accessible for them. So they that is an so the if they do if the endoscopist is comfortable, the time needed for achieving hemostasis and the success of endoscopy will be far better than patient who can do it at the bedside. So we need to balance this out. If the patient is very unstable, we prefer them doing it at the bedside. If the patient is little stable, who can be managed with minimal inotropes or no inotropes, then these patients can be shifted to endoscopy suite and it can be done there. So if there is a variceal bleed, this is a photograph which shows the varices being banded. Here the next picture which shows injection of sclerotherapic agents to these varices to cause occlusion of these varices and stoppage of bleeding. And if there is a lesion or bleeding ulcer, you can see the clip which has been applied. And the upper right side photograph shows a injection of adrenaline which is used to control bleeding from a bleeding ulcer. So whenever we speak of endoscopy, we need to remember forest classifications. So these three classifications that we need to be familiar with whenever we speak of upper GI bleeding. So the Butchard and Rockall score we discussed, this is the third classification. This is endoscopic classification. So it is this ulcers or any bleed is staged from 1 to 3. 1A is spurting bleed. The chances of rebleeding is 60 to 100%. 1B is oozing blood. The chance of rebleeding is 50%. The lower the stage, the chance of rebleeding is higher. Stage 2A, 2B, 2C, the chances are 40 to 10%. So 2A is non-bleeding visible vessel, 2B is adherent clot, 2C is spot in the ulcer crater. And class stage 3 is clean ulcer base, which is a sign of healed ulcer. The rebleeding chances is very low, it is 3 to 5%. So we need to be familiar with this classification. Whenever the endoscopist writes which is the classification, we need to correlate with the chances of rebleeding. These patients must be observed for rebleeds. So what do we do if we cannot control the bleed with the endoscopy? If there is a refractory bleed, we can use balloon tamponade with Sengstegen Blackmore tube or Minnesota tube. It can be used for 12 to 24 hours. So here there will be two balloons. This tube will have two balloons. One is the gastric balloon, another one is the esophageal balloon. So we need to pass this balloon inside. If there is a gastric varices, then inflate the gastric balloon only and then pull it and fix the tube at the tip of the nose. The drawback is it can cause severe it can cause perforation of the esophagus, lower esophagus. If especially the esophageal balloon, if it is uh, inflated too tightly, it can cause esophageal perforations. It can cause decrease the blood perfusion and cause ischemia. Later on, it can lead on to stenosis. And when you're pulling at the nose and putting a band there, it can cause necrosis of the nasal tip. So all these mechanical complications are very much high with SB tube. So we have to be very conscious when we do all these things. And what we do is intermittently deflate after 6 hours and then reinflate, see whether the patient is actively bleeding, and can we go in and see and control the bleeding. So all these things have to be thought of. We have to involve the interventional radiologist. We can ask for a transcatheter arterial embolization of the bleeding vessel. So if we can identify a bleeding vessel, that branch can be embolized. TIPS is transjugular intrahepatic portosystemic shunt, where they place a shunt between the hepatic vein and the portal vein. So once they do that, the pressure in the portal system reduces and this reduces the bleed. So there is, but this causes increased risk of hepatic encephalopathy. But it can be considered in a case of refractory bleeding. So whenever after we do a endoscopy, we control the bleeding, we need to monitor these patients. We have to monitor their vitals, urine output. These patients are at risk of acute kidney injury, hepatorenal syndromes. So monitor the urine output. We have to identify rebleed if it is there very quickly. And hemoglobin, repeatedly monitor hemoglobin and coagulation profile and correct the coagulopathy if it is there. There is risk of aspiration. The complications include aspirations, acute kidney injury, hepatorenal syndrome, myocardial ischemia, and hepatic encephalopathy in a patient with variceal bleed. So to conclude, so I have covered all these things in a brief, in a nutshell. So to conclude, upper GI bleed is an emergency. So these patients have to be triaged early and admitted to ICU early. Hemodynamic stabilization, appropriate blood transfusion strategy with or without acid lowering agents, while also subsequently considering urgent endoscopic assessment and intervention, monitoring for rebleeding, all these improve the patient outcome. We need to have a multidisciplinary team approach because we need to involve a interventional radiologist, medical gastroenterologist. Sometimes, if it is not controlled, even a surgical team has to be involved, blood bank, pathologist. So it's a multidisciplinary team approach. So thank you. So this session is open for discussions. Any questions? Any doubts, any questions? Happy to address. Any role of terlipressin? Terlipressin, as I told you, it can be given as 1 mg 6th hourly. Either octreotide, somatostatin, or terlipressin. So you need to monitor the heart rhythm. Cardiac complications can be there when you are using terlipressin. But it's a good drug. It can cover HRS also if there is any HRS along with noradrenaline if you give. That also will be taken care. So you can use terlipressin. Doesn't endotracheal tube interfere for varicose ligation in case of intubated? No, it doesn't interfere, because you are placing the endotracheal tube in the trachea, and the endoscopist is passing through the oropharynx into the esophagus and stomach, so it doesn't interfere. Only thing is sometimes the cuff can prevent the easy movement of the scope. So sometimes you probably have to deflate the cuff and put the scope and then reinflate it. Anything else? If there is no further questions, then we can wind up this session. Thank you all.
Hello. Thank
What
you,
is
sir.
the best option for interpreted patients? I addressed that. Okay. Thank you.
Thank you, sir. Thank you for your time.
Thank you so much.